Intraoperative considerations in a patient on intravenous epoprostenol undergoing minimally invasive cardiac surgery. In cardiac surgeries, inhaled epoprostenol is more commonly used and has been shown to consistently reduce pulmonary artery pressures. Although inhaled epoprostenol is frequently used in patients undergoing cardiac surgery in both the perioperative and intraoperative setting, patients presenting to surgery on the IV formulation are less common, and little literature currently exists on considerations for its management. Epoprostenol has a very short half-life of 3 to 6 minutes, and abrupt discontinuation can cause rebound pulmonary hypertension, acute rise in right ventricular (RV) pressures, and may predispose the patient to cardiogenic shock. Therefore, careful titration is required. In the issue of the JCAV, a 35-year-old body mass index 33 kg M2 male patient with months of progressive dyspnea on exertion, lower extremity edema, and syncopal episodes presented to another hospital complaining of right arm numbness and tingling and was found to have multifocal acute to subacute cerebral infarcts. Following neurologic workup, a transthoracic echocardiogram was obtained, which showed a large left atrial mass, severe RV enlargement and systolic dysfunction with a fractional area change of 17%. Severe tricuspid regurgitation, NRV systolic pressure of 96 mmHg, systolic flattening of the interventricular septum, and a left ventricular ejection fraction of 65%. The patient was transferred to our hospital for expedited surgical evaluation. A computed tomography angiogram confirmed a left atrial mass consistent with an atrial myxoma. A right heart catheterization during this time demonstrated severe pulmonary artery hypertension, 9351 mmHg, low cardiac output, 3.72 L-min, cardiac index 1.63 L-min M2, and a pulmonary vascular resistance, PVR, of 14.86 Wood units. Limited vasoreactivity was seen with 20 parts per million, ppm of inhaled nitric oxide, INO, post-inotherapy, PVR 14.74 Wood units, cardiac output 3.85 L-min. Additionally, cardiac magnetic resonance imaging demonstrated an RV ejection fraction of 30%. Pulmonary function testing was entirely normal, and a 6-minute walk test was completed without desaturation. The patient was started on triple therapy for newly diagnosed World Health Organization Group I idiopathic pulmonary hypertension with IV epoprostenol, sildenafil, and ambrisentan. Given the patient's extremely high risk for periprocedural complications, including cardiopulmonary collapse and the need for extracorporeal membrane oxygenation, a multidisciplinary team involving cardiothoracic surgery, cardiac anesthesiology, neurology, and pulmonary hypertension decided to postpone surgery until the patient was on a substantial therapeutic pulmonary hypertension regimen. Approximately 2 weeks after initiating treatment, repeat right heart catheterization demonstrated a PVR of 6.25 Wood units and a cardiac output of 7.0 L-min. Given his improvement, a second multidisciplinary meeting was held the following week, during which it was decided that he would be scheduled on the week after for left atrial myxoma excision with possible tricuspid valve repair via minimally invasive right anterior thoracotomy approach. The risks and benefits of the minimally invasive approach versus traditional sternotomy were discussed with the patient, who ultimately chose the minimally invasive approach due to its equivalent surgical results with the benefit of decreased perioperative complications and faster recovery. Operatively, a pre-induction left radial arterial line was placed and defibrillation pads were applied to the patient. An epinephrine infusion was started at 0.04 g kg min prior to induction to support RV function, and an INO was placed in line with the circuit and started at 20 ppm in preparation for delivery after intubation to maximize pulmonary vascular relaxation. IV Epoprostenol was continued at 38 kg min, given the patient's demonstrated improvement on triple therapy and a concern for rebound pulmonary hypertension with acute RV failure in the setting of discontinuation. General anesthesia was induced uneventfully with 2 mg of midazolam, 100 g of fentanyl, 50 mg of propofol, 100 mg of rocuronium, and epinephrine boluses to promote RV inotropy. The patient was intubated with an 8.0 mm single-lumen endotracheal tube, and a right-sided bronchial blocker, 9.0 FR uniblocker, was placed for lung isolation. Vasopressin was started at 0.04 units min due to anticipated post-induction hypotension while on IV epoprostenol, as vasopressin increases systemic vascular resistance while sparing the pulmonary vasculature. A right internal jugular sheath introducer was placed and a pulmonary artery catheter was inserted uneventfully, which initially measured a pulmonary artery pressure of 74/43 mmHg. Intraoperative transesophageal echocardiography confirmed a 2.5 cm mass attached to the interatrial septum. IAS, a severely dilated RV with severely decreased function, and moderate to severe central TR. The femoral artery and femoral vein were accessed by the surgeon with 5 FR sheaths to plan for peripheral cardiopulmonary bypass (CPB), ultimately using femoral inferior vena cava (IVC) and or right atrial and central superior vena cava (SVC) cannulas for drainage. A transverse incision was made in the right chest, and OLV was initiated after confirming the position of the bronchial blocker and inflating the bronchial cuff under direct visualization. A volume control ventilation mode was used with a tidal volume of 370 ml, 5 ml per kilogram ideal body weight, positive end expiratory pressure of 10 mmHg, plateau pressure ranging from 28 to 32 mmHg, VO2 100%, and inspiratory colon expiratory ratio of 1:2. Within 5 minutes of initiating OLV, the patient experienced significant hypoxemia with desaturation from 98% to 80% and concurrent hypotension. Two-lung ventilation was resumed immediately with application of recruitment maneuvers. Pulmonary artery pressures remained unchanged both during and after OLV. The surgical team proceeded to exchange the femoral sheaths for peripheral femoral arterial and venous cannulas with the tip of the femoral venous cannula at the IVC right atrial junction. A repeat attempt at OLV similarly caused immediate desaturation, resulting in the decision to go on CPB. Upon initiation of CPB and discontinuation of ventilation, the patient's saturation on upper extremity pulse oximetry continued to severely decrease alongside a symmetrical decrease in cerebral oximetry saturations. OLV was resumed with hand ventilation but without improvement. Arterial blood gas sampled from the CPB circuit during this period demonstrated pH 7.27, PaCO 244.9 mmHg, PaO2 399 mmHg, and a hemoglobin of 10.0 gdl. On transesophageal echocardiography, the heart remained full and ejecting despite full CPB flows. Notably, the perfusionist was unable to empty the heart adequately, and the venous reservoir was excessively full. The surgeon placed an SVC cannula, and the perfusionist diverted excess reservoir volume into empty collection bags with subsequent resolution of the hypoxia. While on CPB, the patient experienced worsening hypotension, mean arterial pressure 30/45 mmHg with limited response to norepinephrine and vasopressin infusions and phenylephrine and vasopressin boluses despite adequate pump flows. Due to significant refractory vasoplegia on CPB, the decision was made to discontinue IV epoprostenol, which significantly improved the mean arterial pressure. A cross-clamp was applied to the ascending aorta, and the heart was arrested with antegrade cardioplagia. A 2 cm by 3 cm mass was excised from the left atrium and IAS uneventfully, and the IAS and atriotomy were closed. The tricuspid valve was not repaired due to normal appearing leaflets and a concern for worsening RV failure following repair. The cross-clamp was removed, and the heart was reperfused and de-aired. The patient was weaned off bypass successfully, with a focus on maintaining RV function using epinephrine and milrinone infusions, maintaining systemic vascular resistance using vasopressin and norepinephrine infusions, and minimizing PVR using milrinone, vasopressin, and INO at 20 ppm. Cross-clamp time was 32 minutes and CPB time was 90 minutes. Once hemodynamic stability was achieved post-bypass, IV epoprostenol was restarted at 10 kg min. Following thoracotomy closure, the patient was transported to the intensive care unit in stable condition and extubated approximately 2.5 hours later. His IV epoprostenol dose gradually was increased back to 30 kg min on postoperative day 0. His hemodynamics remained stable with cardiac indices above 2.8 L-min-M2 throughout his intensive care unit admission as he gradually was weaned from epinephrine, norepinephrine, vasopressin, and INO over the course of several days. He was discharged home on postoperative day 15. In conclusion, IV epoprostenol has many systemic side effects that may be challenging to manage intraoperatively in patients undergoing minimally invasive cardiac surgery requiring OLV. The anesthesiologist should weigh the risks and benefits of stopping or continuing IV epoprostenol and understand the physiological changes that occur with its use.